All right. So welcome everybody. I'm just going to scroll through so I can say hi to you and see who's here, if anyone I know. Yes, several of you. So I'm Becky and I'm the founder for Power, if I haven't met you before. So we appreciate your time, and we have a fantastic speaker, which is why I had to come and introduce him and take notes and learn as much as I could. So I will introduce him, and then he is going to speak. And we're wanting you to go on and type your questions into the chat. And at the end, we'll go through the questions. So, and even if there aren't a lot of questions, or we may start with some questions, you can also at the end unmute and ask your questions directly. That way we can hear your voice, your loud voice. Okay. So, all right. Let me just tell you a little bit about Dr. Larson, because I just met him recently, probably maybe now 4 months ago or something. But he is a professor of neurosurgery at the University of Arizona, and he's the chief of neurosurgery at the VA Center here in Tucson. So we're really lucky to have him, and so are our vets. And he specializes in functional neurosurgery. So you'll learn what that means today, I think. And specifically, deep brain stimulation is one of those techniques. He went to medical school here at the University of Arizona, which I'm so glad he's found his way back to Arizona. But when he finished med school, he did his residency at the University of Louisville. I think I said that right. He was a professor in neurological surgery. Then he left Louisville and went to University of California in San Francisco, where he was for 26 years, he just said. So, and now he's returned to his roots here in Arizona, and he's bringing with him all these amazing skills from a research perspective and a clinical perspective that can help people with Parkinson's and other types of neurological conditions. So he really is a pioneer in this field. So you have access to his bio there, but just a few things is he's able to, I think of it as like a sniper. That's what he does in the brain. He uses this MRI sort of three-dimensional tool, like a GPS, and he can localize stimulation and other kinds of techniques into the brain. So he also specializes in ablation, which is, instead of stimulating, it's like eliminating the tissue, and drug delivery. And he's done over 1,000 MRI procedures, which is just amazing. So when you consider, who do you want to go to for deep brain stimulation? That's the question I always ask. Like, how many do you do? What's your experience? So, and he works with the research team, and he's involved in gene therapy. So you'll, I think, hear a little bit about that, and also using those techniques to deliver novel medications or therapeutics to the brain. So he has an interest as well in tinnitus, and I'm interested in that because I have it. So I might have to talk to you about it some other time. And it looks like you've actually discovered a new brain region. So that's not something you hear about every day. So anyway, he's going to share his screen and talk to you, and please take notes and chat. And at the end, I'll try to moderate that a little bit. And so thank you so much, Doctor. It's Paul Larson. And I just want to thank you for being here, and it's all yours.
Wonderful. Well, thank you very much, Becky. It's very, very kind of you to give that wonderful introduction and to invite me today. So it's great to see everybody. Going to talk a bit today about biologic approaches for Parkinson's disease. And we'll talk about two specifically. These are, here we go. There we go. That looks better. These are my disclosures. There's a bunch of people that pay me to think about this stuff and then ultimately do it. So we work with a lot of companies to develop new therapies for Parkinson's. I'm also going to show some videos of patients, and I don't want you to think that if you come to our clinic, you're going to end up on YouTube. Patients have given us permission to use their videos and their pictures for educational purposes. So this is a very typical gentleman with pretty advanced Parkinson's disease. He's got a lot of the features that we try to treat. He's got tremor. He's got slowness of movement. You can probably appreciate he's very stiff as well. And if you were to ask this gentleman to get up and try to walk, you would find that he has significant difficulties with starting his walking. We call it gait initiation. He just has a really difficult time getting going. So these are the symptoms: tremor, slowness of movement, stiffness, walking trouble, that we try to treat with medications. And when medications become less effective over time, we think about other ways of treating. Now, medications early on in Parkinson's disease in the first couple of years often work pretty well for a lot of patients. And so a patient can take carbidopa, levodopa 3 times a day, and they can have pretty good function throughout the day. The problem is that as the disease progresses, and we all know that Parkinson's is a progressive disease, that the effectiveness of medication starts to decrease. And there are 2 things in particular that start to happen. Patients start to develop what we call motor fluctuations. So they take their medications and they're in a good, what we call an on state, meaning that they can move well, their tremor is minimal or absent, their movements are smooth, they're fast. But eventually the meds start to wear off and they become slow, stiff, tremulous, or any combination of those things. We call that being an off state. And patients will start to take medications based on their neurologist's instructions. They'll take them closer together, or they might take a higher dose. But despite those adjustments in medications, they fluctuate throughout the day. They go up, they go down, they're on, they're off. And they might go through these sort of peaks and valleys on this roller coaster, 4, 5, 6, 7 times a day. The other problem is that they can develop something called dyskinesias. So dyskinesias are involuntary movements. If you've ever seen a video of Michael J. Fox, he's sort of the poster boy for dyskinesia. It's these sort of involuntary, looking like you're just restless all the time, or arms are flailing, moving when you don't want to move. And dyskinesias are actually a complication of taking these medications for a number of years. So if you take carbidopa, levodopa long enough, it can, in some patients, result in the development of these dyskinesia movements. So when patients either become fluctuators or they develop dyskinesias, or sometimes it's both, we start to think about other types of treatments. We start to think about surgery for their Parkinson's disease. Now, as I think we alluded to in the beginning, in the introduction, there is this technique that we use called deep brain stimulation. And this is currently the sort of gold standard surgery we have for Parkinson's. It's essentially a pacemaker for your brain. There's a battery pack that goes in the upper part of the chest, just below the collarbone. That's connected to a wire that runs under the skin, up behind the ear, up to the top of the head, underneath the scalp. And then the end of the electrode goes down into a particular part of the brain that's involved in control of movement. And by stimulating this part of the brain, we can change the abnormal pattern of activity that's in this motor circuit in the brain that's caused by Parkinson's. And we can make patients' symptoms better. So it's the best thing we have. It's if you go to a movement disorder center, if you came to our clinic, for example, and you were fluctuating or you had dyskinesias and everything else looked good, this is what we would offer you. It's a wonderful therapy, but it does have some disadvantages. It's a symptomatic therapy, and that means that it doesn't stop the progression of Parkinson's. It doesn't alter the brain biology itself. So it doesn't stop Parkinson's from slowly progressing over time. It makes the symptoms better. It's a hardware-based treatment. That means that it's got a battery and wires. And so there are a higher level of complications that are inherent when you're doing an operation that puts stuff in you that shouldn't be there. These batteries, wires can get infected. They can slip out of position. They can erode through the skin. It's a treatment that's dependent on electricity. So there's a battery. The battery eventually wears out. So you have to have the battery surgically replaced every 3 or 4 years, or you have to have a rechargeable battery that you can recharge through the skin. But there's a bit of ongoing maintenance of the system, and it's a bit time consuming. It's time consuming for your neurologist to sort of adjust the stimulator settings over time as your Parkinson's gets worse to try to maximize improvement. You have to come in and have batteries replaced, or you have to recharge the battery a couple times a week. So there's a bit of time and compliance requirement inherent with having this. Now, for many years, dating really back to the 1980s, we've thought about biologic treatments for Parkinson's. Parkinson's involves a very specific part of the brain where the brain cells are dying off for reasons that we don't understand. And a logical thing would be to try to transplant new brain cells into that area to replace the ones that are dying. The problem is where you get these cells. And in the early 80s, there were some groups that tried to harvest cells from what's called your adrenal gland. The adrenal gland is a gland that sits right above the kidney, and the cells are similar to dopamine-producing cells in the brain. So patients were transplanted with cells from adrenal glands, and it really didn't work. We then tried what we call fetal cell transplant. So this was harvesting dopamine cells from the brains of aborted fetuses, human fetuses, and then putting them into the brains of patients with Parkinson's disease. This is a complicated thing. There are ethical issues that came out of this. Ethics aside, from a scientific standpoint, it looked like this might work in some early studies. And early studies are often what we call safety studies. What that means is that everyone gets the transplant. They know they're getting the transplant. And so there's this thing called the placebo effect, where if you're getting a treatment and you're hoping it's going to work, or you think it's going to work, it often does. It can actually help for a while. We have a way of countering this effect by doing what we call a phase 2 study, or a placebo-controlled study, where some patients actually get a transplant and others don't. And the patients and their caregivers and the neurologists that are evaluating them don't know whether they really got the transplant or not. And then they compare those two groups over 6 months or a year or 2 years to see, does one group really get better than the other? And it turns out that there really wasn't a difference between the two groups. So we didn't demonstrate there was benefit with a fetal cell transplant. And in one of the studies, over half the patients actually developed quite bad dyskinesias, even when they weren't taking their medications. And so this was an unexpected side effect of getting a transplant. And fetal cell and cell transplantation kind of died on the vine at that point. There's been a recent resurrection, and we're going to talk about that at the end today. But these early studies did show a few things. It showed that we could actually do cell transplant. We could technically do it, and we could get cells to survive in the brain. But there were some significant issues that were raised as well. And one of them is, you have this thing called an immune system, and your immune system is very good at detecting if there's things in your cells in your body that are foreign, and it'll go off and try to kill them. So these patients would have to be put on very high doses of immunosuppressant medications, much like patients that get a kidney transplant or a liver transplant. And those medications have side effects. The cells that we put in, it was not clear if they really sort of spread and grew and integrated into the local brain network, or did they just sort of sit there and just sort of produce dopamine? And, is it important for them to integrate into the local network? So these were all questions that we had to go back to the drawing board with. And many, many groups around the world have been struggling with these questions over the last couple of decades. And again, at the end, I'm going to talk about, we're about to see a big reprise in cell transplantation. In the meantime, however, we didn't stop looking for an answer. And another wonderful way of trying to alter the biology of the brain in Parkinson's is with a tech called gene therapy. So gene therapy uses an inactivated virus, and viruses kind of have a bad reputation right now because of the pandemic, but not all viruses are bad. Some viruses are benign and you can use them in a positive way. So we use a virus basically as a method of getting a good gene into the brain's, a specific part of the brain in patients with Parkinson's, and we can get that part of the brain to have a new biologic function in a beneficial way. So this is kind of what a virus looks like. They're kind of these funny looking things. They have these little feet on them. And these little feet can attach themselves to a brain cell. So this big blue thing is a brain cell. The virus contains its own little fragment of DNA. DNA are basically instructions that tell your cells what to do. And the virus injects its DNA into the cell that it's attached to, and then that cell's function is altered. Now, if it's a bad gene, like the gene that causes the common cold, it gives you respiratory symptoms for a couple of days. We can manipulate these viruses. So we can take a virus and we can get rid of its bad DNA, and we can put good DNA. We can put a gene that gives instructions to cells to do something positive. Like make a growth factor that helps promote brain cell survival, or express a protein that helps that cell produce more dopamine. And we can deliver these modified viruses with the good genes in them. We can put them in the brain and use that virus as a way. I used to say a taxi cab. Now I have to say Uber, because no one takes taxis anymore. But we basically use the virus as just a temporary carrier to get the gene, the good gene, into the cell. The virus then detaches and dies. So it just serves a purpose very briefly. This is what a real virus looks like. You can see these little things that are coming out of the periphery. Those are the little things that attach to cells. This is a particular virus called adeno-associated virus, or AAV. And AAV is a very interesting virus. It's naturally occurring, so it's found in nature. In fact, many of us get exposed to it and don't know that we ever got exposed to it. But you can draw blood from patients and you can detect if they've been exposed to this virus before, and a lot of us have. So it's probably a very old virus. Maybe it caused disease in many, many years ago, maybe millions of years ago. Maybe it's a virus that was active in the animal kingdom at some point, but it doesn't seem to cause disease in any animals that we know of. When you put it in the brain, in the central nervous system, or CNS, it doesn't really trigger much of an immune response, which is good. It means that your body sort of doesn't try to attack it. And it loves to latch on to brain cells or neurons. It has a strong affinity for neurons. And these are all important characteristics when we're thinking about using a virus to get new genes into the brains of humans. Now, I alluded to this earlier, but when we started to think about constructing clinical trials to see if gene therapy works, we had to sort of learn about failures of the past. And so, we tried human fetal allograft. That means a transplant. We tried pig cells to try putting them into the brain. We tried infusing growth factors into the brain. When we did a phase 1 or an open label trial, that means everyone's getting the stuff. Everyone knows they're getting the stuff and they think the stuff is going to help them. All those trials looked great. Everyone got better. When we then did a phase 2 placebo-controlled trial, meaning some people really got the stuff and some people didn't, and no one knew who got what, there was really no benefit in these therapies. So we had to really, move with caution when you think about doing something new. Now, why do these phase 2 studies fail? Well, I already mentioned that this placebo effect. So that's one issue that we have. And even if you're in a trial and you think that you may be getting the stuff, whether you get it or not, you may actually have an improvement temporarily in your function. So the placebo effect is certainly something that's important to think about as something that could cause these trials to fail. I'm a surgeon, so I'm the one that's delivering this stuff to the brain. And I always think about, are the delivery methods that we're using really adequate? And when we started thinking and started doing gene therapy in humans, we spent a lot of time sort of calculating, okay, well, this is the part of the brain that we want to cover with virus. And if we put this much fluid with virus in it into this structure, we're going to get this much coverage of that structure. And we know we need to get at least 50% of this structure sort of covered with virus in order to see an effect. It was all very theoretical. It was engineers and mathematicians and fluid dynamics people sort of estimating and guesstimating what we were going to see. And in a lot of these studies, we did not see widespread coverage of these targets. We saw these little dark, we call them hot spots. So these little tiny, if you see in this lower right panel, these little dark spots where the virus went. We wanted to see big, large areas, not these little tiny spots. So there's a couple of things that we learned along the way. And one of them is, how do you deliver fluid to the brain? And the simplest way to do it is just like getting a flu shot. You put a needle in the muscle, you have a syringe, you push a plunger, and it delivers fluid to that tissue. And when we started doing gene therapy in the brain, that's kind of what we did. We had a very, very fancy needle, but it basically had a syringe at the top of it. And we would very carefully and slowly depress the plunger to deliver the fluid. And that results in a delivery method that we now refer to as bulk flow. That's what you see on the left. So this is a needle coming down from the top of the screen. And what bulk flow does is it gives a very high concentration, this big dark blue blob. It gives a very high concentration of virus. But then you're dependent on what we call diffusion, the sort of passive spread of fluid into the tissue, like a sponge would take up fluid. The problem is the brain is really not like a sponge. The brain is full of fluid itself. And so the fluid doesn't really spread much beyond the injection site. A better way to deliver fluid to the brain is with a technique called convection enhanced delivery, or CED for short. That's the right. So that's a needle. And instead of just sort of blopping fluid through it with a syringe, we're going to deliver fluid slowly and steadily using an infusion pump. So the syringe is going to go on a pump, a mechanical pump that pushes the fluid at a steady and constant rate. And what it allows you to do is it allows you to push fluid through the tissue and get a much larger area of coverage. So this was one thing that we really learned. In order to really deliver things like vector, and this applies to other drugs as well, to the brain, you have to use convection enhanced delivery. The other thing we learned is that there's this phenomenon called reflux. So most needles, like you see, we call them cannula. Most cannulas it's a big long tube, and it's the same size along its entire length. So when you deliver fluid through a cannula like this, fluid will start to be delivered at the tip, but there's always a little potential gap between the brain itself and the cannula itself. And this creates a sort of a little pathway that fluid can take, and it can leak up and around the cannula. This is a phenomenon that we call reflux. And when you start to get reflux, the fluid, in this case, the virus, is not going to stay at the tip of the cannula. It'll start being delivered at the tip of the cannula, but then it can start to leak up around the cannula itself, and it's going to start to spread beyond the area of the brain where you want to put it. So we learned that if you build little, what we call steps, little rounded steps into the cannula, it will keep the fluid more in the area where you want to keep it. Now, eventually, if you deliver a large enough volume, you can get what we call a little reflux. And that's why we always put a second step, but it keeps more of the vector where you want it to be. So this was another innovation that we learned in these early trials. So I want to talk about one particular study that we did. We were using a virus to deliver an enzyme. Enzymes are proteins that help our brains make things. This particular enzyme is called amino acid decarboxylase. And at the end, there's going to be a test where you have to draw these little figures. So I'm not going to answer your questions unless you can draw these little molecular structures on the right. But AADC, amino acid decarboxylase, it's the enzyme that helps our brain convert levodopa, the medication that you take, into dopamine, which is the dopamine that your brain can use. So when you take your medications, and when your brain is trying to make dopamine, AADC is the little enzyme that is the last step in converting those things to dopamine. Now, as Parkinson's progresses, the level of this enzyme in the brain is dropping. And that's why your medications become less effective as the disease progresses. So the rationale was to try to replace this enzyme. And it turns out that monkeys get a form of Parkinson's as well. And when we treated monkeys with this technique, we made them better. So the upper panels, this is what we call a PET scan. A PET scan is a way of non-invasively imaging the brain and seeing if there's dopamine active. And on these scans, dopamine activity is this bright red color. So you can see in this animal, on one side of the brain, there's dopamine in the motor part of the brain, but there's not in the other. And when we take this animal and we treat it with gene therapy carrying that AADC gene, you can see that we restore dopamine function. So we've now got an orange blob on both sides. You can see it down here as well. So this is the normal side on the left. The right side, there's an absence of that yellow and green. After we treat, we sort of restore that normal dopamine function. This was work done by a former colleague of mine, Christoph Bankovich at UCSF. And importantly, the effects of this gene therapy seem to last for a very long time. So the wonderful thing about PET scans is that they're non-invasive, they don't hurt humans, they don't hurt the animals. And you can see a couple of these animals that were treated with this gene therapy lived out to over 96 months. And at 96 months, there was continued production of this AADC enzyme in the brains of these animals. So we took this as a positive sign, and we did what we call a phase 1 study. So this was adeno-associated virus carrying this gene for AADC. We did it in 10 patients. We used this convection-enhanced delivery technique. We used sort of a more traditional, at the time, it was sort of the standard way of delivering, which is to put 2 cannulas into the brain without really being able to see what was happening inside of the brain. We're just doing this in a regular operating room. So this is actually the top of a patient's head. And you can see there's this big sort of arc-shaped system that's a very precise system for putting devices into the brain itself. And you can see there are 2 infusion cannulas that are infusing this virus. This is what one of the cannulas looks like. And schematically, this is what it looks like. So the part of the brain that we want to put the vector or the virus in is called the putamen. So we basically had a little holder on that device outside the head that had 2 little guides that we could pass cannulas through. We would put 2 cannulas in simultaneously, and we would use convection-enhanced delivery to deliver virus. Took about an hour on each side to do this. Patients were asleep. This is the surgical setup. So these 2 cannulas that are going down into the brain. You can see there are these little infusion lines. They look like IV lines. These are going off to a pair of pumps that are off the picture. And they're pumping this virus into the brain using this CED technique. Now, this is as much as you can see at the time of the operation. You can't see inside the head with this particular technique. So, your guess is as good as mine if the vector is going where we want it to go and if it's staying put. We believe that it was based on our modeling. And these were the outcomes of these patients. So their baseline, these are what we call motor scores. UPDRS is a unified Parkinson's disease rating scale. It's basically a way of measuring how bad your Parkinson's is. And higher scores are worse and lower scores are better. And if you look at when these patients were off medications or on medications, they had better scores at 6 months after gene therapy than they did before. Now, the big caveat here is that this is a phase 1 study. So that means that everyone is getting the stuff, everyone knows they're getting the stuff. And most phase 1 studies actually look good. The outcomes are usually good. The important thing is the safety was good. And if you look here, these are these PET scans. These are now humans. So this is a part of the brain called the putamen. It's part of the circuit that's involved and affected in Parkinson's disease. The front part of the circuit is not affected by Parkinson's, but the back part is. So there's not enough amino acid decarboxylase back in the back part, and there's not enough dopamine production. This is 6 months after the same patient. So you can see the back part is now bright. It wasn't before. So we had clinical data suggesting that the patients were better, but also this was nice because we had imaging data showing that the brain really is producing more dopamine. Imaging is not really affected by the placebo effect. So if it's there, it's real. If it's not, it's not. Now, that was a phase 1 study. It looked great. We did some phase 1 studies using growth factors. The theory there was that we were going to make brain cells survive longer and also help improve symptoms in the short term. We did several phase 2 studies in those trials, and they were negative. So, we've been thinking a lot over the last 15 years about how can we make gene therapy better. And 2 things that we've come upon that we've been using for the current studies that are being done is working on making it less invasive and being able to see what's happening in real time. So let's talk about invasiveness first. So this is the surgical plan for one of our early gene therapy trials involving this growth factor. And this was not using convection enhanced delivery. So we were using the syringe. And so we're getting these little blobs of delivery. And I mentioned earlier that, we don't get a lot of coverage if you're doing that. So what you have to do is you have to make numerous needle passes or cannula passes into the brain. And this is 4 cannula passes on each side with multiple deposits along each of these tracks. So this is complicated, right? And this is invasive. I mean, this is, sticking something in your head 8 times, 4 on each side. This seemed overly complicated and overly invasive to us. So a major goal in recent years has been to minimize this. Better efficiency while at the same time being less invasive. The other real innovation was developed by, again, my partner for many years, Chris Bankovich at UCSF, now at Ohio State. He figured out that if we delivered the virus in an MRI scanner, so with the patient in an MRI scanner, and if you mixed contrast material, so when you get an MRI, what we often will do is you'll get an IV and the doctors will put what we call a little contrast in your IV. It's clear fluid, but it lights up brightly on MR imaging. And what Chris did is he put that contrast fluid in with the virus. So he co-infused the virus with this contrast material. And this is a monkey who is an older monkey, has Parkinson's-like symptoms, that's getting gene therapy. And Chris is using this real-time MR technique, and he showed that you can visualize these infusions in real time. And moreover, what he found is that the area where you see the enhancement, where you see the brightness on the MRI as you're doing the procedure, correlates nearly perfectly with the part of the brain where the virus latches on and has its effect. So on the left are MR images during the infusions with these animals. After the animals subsequently die, you can examine their brains and you can see where the virus went, and it correlates very, very nicely. Now, coincidentally to this, I and two of my partners in San Francisco were working on a system where we could use surgery in MRI scanners to put deep brain stimulating electrodes in patients. We got tired of the older techniques of doing DBS. We wanted to make it less invasive. We wanted to make it safer. We wanted to be able to see where the electrode was going in real time. And out of that work was born a commercially available device that a company in Southern California that we have nothing to do with developed. And it's a system called ClearPoint. And it's a system that allows you to put a patient to sleep, temporarily mount this sort of plastic aiming device that you see on the head. And then you can use this device to deliver whatever you want to a very specific part of the brain. You can deliver a deep brain stimulating electrode, or you can deliver an infusion cannula. And that's what Chris did. You can get pictures during the implantation procedure. This happens to be a deep brain stimulating electrode placement in a patient. You can see this dark line. That's the actual stimulating electrode that we placed with the MR visualization. So what Chris did is Chris developed an MR safe cannula. So this is one of those stepped cannulas that I showed you before. It's made out of ceramic. So it's safe to use inside of the MRI scanner. And so this is what this system looks like. We have a patient that's in the MRI scanner. The inside and the far end of the MRI scanner has been draped with a sterile drape. So we can create a sterile field. So it's safe to do surgery on a patient while they're in the scanner. There's an infusion pump that's got a syringe on it that's loaded with virus. And it's delivering convection enhanced delivery along an IV line. We call it the infusion line. It's going to this little cannula that's going through this aiming device and down into the brain through an incision that's about 2 millimeters in size. So a dime is about a millimeter thick. So it's about the thickness of a couple of dimes. And this is what it looks like. So this is a patient, a Parkinson's patient, that was a participant in one of our studies, the world's first MR-guided delivery of gene therapy using this MR-guided technique. And it looks like this goes really quickly. This is about 5 hours worth of work. But you can see that there's a part of the brain called the putamen. It's kind of this long, sort of dark structure on each side. And we're putting 2 cannulas in, one initially in the back part of the putamen right there, and then another 2 in the front. And we're delivering vector to the brain. We're delivering virus to the brain. And we learned a lot by doing this. We learned that when you infuse a fluid into the brain, whether it's a virus or whether it's a drug, let's say you're trying to treat a brain tumor with chemotherapy, or you're trying to treat something like Parkinson's disease or Huntington's disease with a drug or a virus, the fluid does not stay put where you think it's going to stay. You think that the fluid is going to stay just at the tip of the cannula, and it's going to sort of fill the structure up, kind of like blowing up a balloon. It's going to be nice and well behaved. And it turns out that that's not at all what happens. So one of the things that we visualized, which we weren't really expecting, was this phenomenon called perivascular spread. So your brain has got blood vessels all through it. And there are little blood vessels that run through these structures that we're trying to infuse. And these blood vessels, they have a little fluid space around them on the outside of the blood vessel. So these are fluid spaces. As the vessel is running through the brain tissue, there's a little fluid space around it. So it's called the perivascular space. And this is a very efficient pathway for fluid to leak away from where you intended it to go. So on your left, I'm going to start this movie. We're going to start an infusion on the left, this white, and it's going to start off pretty good, but then you're going to see this white streak going up to a completely different part of the brain, where we don't really want this vector to go. And it turns out that there's a little blood vessel that's running through this part of the brain, and the virus is spreading. It's not spreading in the blood vessel, it's spreading around the outside of the blood vessel. And this is a phenomenon called perivascular spread. Now, it's not dangerous. If the vector goes to this part of the brain, it's not going to cause a bad side effect for this patient. But what it is going to do is it's going to lower the effective dose of virus to the part of the brain where we want it to go. Let's look at another example of this. We're going to look at the other side now. So on your right side, we're going to start an infusion. And very quickly, that vector is going to start spreading just all over the place. And the vector spreading beyond the intended target, again, it's going to lower our chances of seeing benefit in this patient because the vector is just going away from the intended target. We call this non-targeted delivery. And again, it's not dangerous, but it lowers our chances of having an effective trial, and it lowers our chances of proving that a new therapy can be effective and getting it FDA approved. We knew that reflux was a potential issue, and it turns out that it really is. So we're back on the left now. So the putamen is down here. I've just drawn an orange line at the top edge of the putamen. So we're going to start an infusion, and it's going to start off pretty well, but then it's going to start to reflux. And all the white stuff that's going above that orange line is just going away from the intended target. And you can see by the end of this infusion, there's actually more vector outside the target above the orange line than there is in the target. So these are likely reasons why some of our early phase 2 studies were not successful. It's not that the preclinical research wasn't good. It's not that the preclinical animal studies in monkeys was not good. It's that we didn't understand these delivery issues, and we were sort of just sticking a needle into the center of a structure and trying to fill it up from the middle. And it was naive thinking. It was not really what was happening. We were getting this non-targeted delivery. So we've learned a couple of things. I'll just show you pictures. Pictures are better than texts, particularly near dinner time. So we learned that instead of trying to fill up a structure from the middle, we should do what we call stacked infusions. So we put the cannula in, we get an infusion going, and then what we do is we lower the cannula to do the second part of the infusion. And what it does is it puts that second step in the first infusion ball, and that seems to help resist reflux. Also, by moving the tip of the cannula, if you are getting spread around vessels, perivascular spread, by advancing the cannula, you move the infusion away from those vessels, and it can keep more of the vector in the intended target. We realized that was so effective that we started what we call a continuous infusion, but this is what a stacked looks like. So we're going to, again, on your left, we're going to do an infusion sort of in the upper part of the structure, and then we're going to push the needle deeper, and we're going to get one in the bottom part of that structure. And you can see no reflux here because this first infusion ball tends to act like a barrier. And when we do the bottom one, we can increase the rate and not get reflux. So this was one strategy. The other is this, what we call a progressive or a continuous infusion, where we actually slowly push or advance the cannula continuously as the infusion is happening. And that keeps the tip moving away from these vessel spaces. If you get leakage along a vessel, it's okay. You're going to move past it in a couple of minutes and you'll get more coverage as we go. This is what that looks like on the right side. So we're going to see We're going to start an infusion. If you're really good, you'll see it'll start to reflex a little bit right there. It starts to kind of creep up. And when that happens, we start advancing the cannula. It gets that second step into that infusion area, blocks it from refluxing more. And these infusions are a lot prettier than the early ones that we had. The last concept, and I picked the most complicated thing for last, just to tax everyone's brain, is how much volume to put in. So we were really guessing in the early days about how much volume we should put in. And, you know, your brain tissue is like a box from Amazon. Most of what's in it are the peanuts, right? The little styrofoam peanuts. Your brain cells, the neurons, actually constitute a very small volume of your brain. Most of your brain are other cells called glial cells that are kind of packed around them and help support them. So if you want to cover a certain volume of tissue, and like let's say in the putamen, and let's say we want to cover 1,500 cubic millimeters, that's about 1.5 cubic centimeters of brain tissue. We only have to put about 500 microliters of vector in to get coverage. It's not a 1-to-1 ratio. So it's about a 3-to-1 ratio. The average human putamen is about 4 cubic centimeters. So we can sort of draw a line and we can say, okay, if we get an ideal infusion and we have a structure that we want to cover and it's 4,000 cubic millimeters, to get half of that, we need to put in about somewhere between 900 and 1,000 microliters of fluid to get half that covered. Now, this is a new concept. This was not something that we had in the early trials. This was a concept that was developed by one of my colleagues, Mark Richardson, who was a pupil in Chris Bankovich's lab and trained with us at UCSF. Now, I showed you a few minutes ago that that's an ideal infusion. I just showed you that these infusions are rarely ideal, right? You get perivascular leakage, you get reflux. And so it's not usually an ideal 3-to-1 ratio. It's closer to a 2-to-1. So we looked at studies that we had done in the past, and we looked at studies where, you know, in 2004, when we planned the first AADC trial, in 2007, 8, 9, when we were planning and executing those growth factor trials, we used mathematical modeling to try to predict, okay, if we put this volume of fluid in, we're going to get this amount of coverage of the putamen. And if you look at the volumes we were using in the past, in a number of studies, we were all down here in this left lower corner. We were using very small volumes, as low as 50, 100, maybe 300 microliters of fluid. We were expecting that would give us 50% coverage. We were expecting it to be about up here where this 2,000 line is. We were way below that. So what we were doing is we were effectively massively underdosing these patients, we think. And that may be why in the phase 2 studies, we didn't really see the degree of clinical benefit that we thought we would. So we were too conservative, we think, early on. Now, in terms of efficiency, we thought about, mechanically, how are we doing this? The studies that I've shown you so far were kind of coming through the top of the head to get down to the putamen. We were really doing that because that's the way we do deep brain stimulation. It's an approach that's familiar to us. We knew that it was safe. And for many, many years, Chris Bankovich kept saying, the putamen, it's a skinny, long structure. It runs front to back in the brain. Why are we coming at it from the side? Why don't we come at it from the back of the head? And that way you could actually get the same amount of fluid infused, but you could do it with one pass of the cannula instead of two. And I was resistant to this for a long time until some of my colleagues that were doing epilepsy surgery started to use these posterior approaches, incisions, little holes in the back of the head, to put little laser fibers down into the temporal lobe, which is right below this blue thing, the temporal lobe, and we're zapping the temporal lobe to treat seizures. And lo and behold, their safety profile was excellent. It was a safe approach. It allows us to deliver much larger volumes. And we can even get way up to, in one of our current studies that's just finished, 1,800 microliters of fluid. This is 23 to 25 times more fluid than we were delivering in these early studies. And it's given us a much better chance of seeing benefit with these treatments. So this is an actual surgical plan in a human. So this is sort of a side view of the head. So the forehead is on the left, the back of the head is on your right. We position the patient's face down. So this is a patient who's under anesthesia, face down in an MRI scanner. We mount these little devices on the back of the head. Again, it's basically, we don't even make an open incision. We use a little drill. It makes a 4 millimeter opening in the skin and the skull. These are the infusion cannulas that go down into the brain. And this is what it looks like when we do the infusion. So this is both sides. So bilateral infusion in the putamen through this posterior approach using this MR guided delivery. Now, you'll see that there's definitely spread along blood vessels. If you look at this upper left, as we start to come into view here, you'll see that there are vessels that are leaking down below the target. If you look at this lower left panel, you'll see as it goes, you'll see it looks like little clouds that are emanating past or outside. So these are still not perfect infusions, but the efficiency is way, way higher than we did with the early studies. All right. So this is a short list of companies that are currently developing biologic treatments for Parkinson's disease, and a few also for Huntington's disease. Now, most of these companies are doing gene therapy, but a number of these are now starting to revive stem cell transplantation for Parkinson's. And they're using a very cool technique where they can take your own cells from a skin biopsy. So it's sort of like going to the dermatologist. If you live in Arizona, I'm sure that you've had something scraped off your skin at this point in your life. I've got many scars from having grown up here. But we can basically do a skin biopsy, take your skin cells and convert them into dopamine-producing cells, and then give them back to you with one of these procedures. And Blue Rock, which is this company in the upper right, they're currently doing a cell transplantation trial for Parkinson's. It's not the skin trick. Aspen, in the lower left, is about to start planning for a trial to do skin cells. And many of these other companies are doing both cell and or gene therapy. So, and there's some big names on here. I mean, you don't have to be a doctor to know, Bayer, Lilly, these are companies that are big and have a lot of resources, and they realize and recognize the potential of these therapies. So it's very, very exciting. So that's probably enough of me prattling on. I'm going to stop sharing my screen and happy to answer any questions at this point. I appreciate your attention late in the day. Everyone should be eating dinner or getting in the pool. Oh, Becky, you're muted.
All right, that's better. So I was looking at the chat. I might start with a few of those, and then you all can jump in the audience. So this was from John, and I know if I don't get it right, John, you can ask it yourself. But he asked about, do you have to repeat this infusion? It's kind of like, how long does it last? Is it a one-time thing?
I see. Yeah, I see his question. Is the infusion? Yeah. So that's an excellent question. So it's a one-time procedure, and that's the other exciting prospect of these biological approaches is that, deep brain stimulation, it's not really, you're not altering the underlying brain function. You're just sort of somehow changing the abnormal patterns in the circuit, and you've got to, there's maintenance, right? The nice thing about gene therapy is that it's a one and done approach. And Chris's animal studies showed that, the virus, the genes that the viruses deliver continue to produce enzyme, for example, in an animal, we know at least 8 years. And we have patients in the very first human studies that we started doing in 2004. If you can believe that, it makes me feel old because I am old. And those patients, many of them are still getting PET scans, and they still have, show increased activity. So it is a one-time procedure.
I have a follow-up if someone else. I wanted to ask you, so once it's in there, this enzyme that creates the dopamine from levodopa, I'm assuming people they're having to continue to take levodopa because they're not making enough of their own. And if that's the case, and they still have Parkinson's disease, do they develop these dyskinesias? Or is there something about the infusion that makes it more a better process?
Yep. So that particular study, that's the adeno-associated virus carrying the AADC gene. So what happens in those patients, if that therapy works, what will happen is you'll get a similar response or a better response to your levodopa, but you'll need to take much less of it, right? Because all of a sudden we're making your brain much more efficient at processing levodopa. So I didn't get into the nitty gritty of the outcomes of that paper. I can certainly do that. We can do that another time. But what we found in those patients was that they had better motor function on much less medication. In fact, one of our patients, it's not unusual for patients to cut their Sinemet in half. They'll take like 1.5. So this was someone that was taking, a 2.5 tablets of Sinemet every, I think it was 5 hours, or 5 times a day, I should say. And they were down to trying to take like a quarter of a pill. I mean, they were on far less than 50% of what they were on before. Now, the dyskinesia thing is interesting. This was one of the concerns that we had. If we're making your brain better, more efficient at processing oral levodopa, are we going to make your dyskinesias worse? We didn't see that, although we certainly saw it temporarily. So in that trial, we had patients that developed more dyskinesia, and what we simply did is we had them reduce their meds. Dyskinesias got better, and they were better on lower doses of medications. It's interesting. One thing that we weren't really expecting, but we saw, is that the off medication scores, meaning your motor function with you off medications, got better after AADC gene therapy. And it does make sense because that enzyme is also involved in us making our own dopamine. So it actually, we think, made the brain better at making its own dopamine. So that study is in a phase 2 trial that started, and now it's kind of halted, and we're waiting to see what the sponsor is going to do. But that's an exciting thing for sure. So I don't know if that answered the question.
Yeah, no, that's good. That's good.
I had one, there was one, Scott just direct messaged me, so you're not going to see this one.
Okay.
But it's a good question. Do you mind if I?
Yeah.
So he said, what about patients with MCI? So MCI is mild cognitive impairment, for people that don't know what that means. As you know, Parkinson's is very commonly associated with some memory trouble as time marches on. It's very common to develop memory difficulty. And there's sort of a couple of categories of severity of cognitive impairment. And the worst is dementia, but you can have what we call mild cognitive impairment, or MCI. So this is a thing in deep brain stimulation. We know that in deep brain stimulation, if you have dementia, so if you have significant cognitive impairment, poking holes in your brain is not a good idea. These trials, by definition, one of the criticisms of these trials is that these are really cherry-picked patients, right? They're highly motivated patients. They're looking for something different. We have inclusion-exclusion criteria to decide who's appropriate for a study like this, and you try to pick people that are going to last, right? You're gonna try to pick people that can come in for evaluations and do that for many years, because we want to follow these patients pretty much indefinitely. So one of the criticisms of these studies is that we have usually there's an exclusion criteria if you have any sort of significant cognitive impairment. And the philosophy behind that is that if you've got someone that's on the brink of dementia, and you do gene therapy, in a year or 18 months, you're effectively going to lose them. They're not going to be able to come in. They're not going to be able to tell you what's going on. And you're going to lose that data point. You're not going to, you're going to lose the ability to kind of learn from that patient. So we don't know yet. We have not seen significant cognitive decline in any of these patients. And we have had some that would fall into the mild part of mild cognitive impairment. We don't know that it really helps cognition. We know it helps the movement symptoms, but the cognitive piece is still a really big problem that we don't have a good answer for.
I wonder if you could answer the question about non-motor symptoms. Are there any other non-motor symptoms that these therapies may be able to address?
Yeah, that's a good question. We just finished a growth factor trial. So there's a substance called GDNF. If you've sort of followed Parkinson's research, you've probably heard of this. It's this is not a great analogy, but I'll tell people it's kind of like fertilizer for your brain. It's what we call a growth factor, and it seems to promote cell survival and seems to prevent or slow cell death, and that's the underlying problem in Parkinson's, right? So there was a study in the UK by a good friend of ours who tried just putting tubes in and just sort of infusing GDNF. The actual substance, the protein in this part of the brain, and it didn't really work. What we are doing is we're teaching the brain cells in this region to make their own GDNF. So it's a gene therapy approach. And we are delivering it. We delivered it not just in the motor circuit, but we delivered it in the front of the motor circuit, where some of it is going to get into what we call the front part of putamen. We think that's the part of putamen that's involved more in mood and cognition. So I'm very curious to see if those non-motor symptoms in those patients are slowed. Things like cognition, things like mood impairment. So the jury is still out.
I know someone asked about is this FDA approved, and or are they recruiting? Are you recruiting right now in a clinical trial?
Yeah. So we're not. None of this is FDA approved yet. We are. So part of the reason a big reason I came back to Tucson, is that the number of people, that surgeons and centers that participate in these trials, is very small. And so there's not a lot of people doing this. The studies have been sort of concentrated in just several centers, we're on the verge of a phase 2 GDNF gene therapy trial. We're on the verge of a phase 1, the skin biopsy cell transplant trial. There's a trial that we're about to start phase 2 for Huntington's disease. Gene therapy approach. And we're going to create basically an infusion center here in Tucson to offer all of these therapies. So people can come just not only from Arizona, but from all over the country to get them here. But none of this is FDA approved yet. It's all still in phase 1 and phase 2, but it's going to happen. The sheer number of companies that are developing and getting ready to start trials is mind-boggling. It's just exploded, and the number just it's growing at an exponential rate. So the biologic field is here to stay, and it's just it's not a question of if, it's just going to be who gets across the finish line first for an FDA approved therapy.
Awesome. Let's see. Anybody else? Does anyone else want to ask a question out loud? You can unmute yourself.
I want to ask one, and this might be kind of too soon, but would things like DBS exclude somebody from being a good candidate for this?
That's an awesome question. The FDA has had a bias in the past, and I understand where it's coming from. They want to make sure that when you're doing something very novel, very new like this, the effects of it are known to be from the intervention that you've just done. So if you're going to enroll a patient in a gene therapy trial or a stem cell trial, they do not want them to have had deep brain stimulation. And the argument is, well, they've already had surgery. DBS is really interesting. You can put an electrode in someone's brain and not even turn it on, and it can make them better. And it's something called the microlesion effect. It can make tremor better short term, very rarely, but it can make it better permanently. So there's been this bias that if you've had DBS, you can't be in one of these trials. I and others have tried to convince the FDA that actually that's not reasonable. The nice thing about deep brain stimulation is you can turn it off. Recruiting for these trials is tough because, a patient comes, they're a fluctuator, they got dyskinesia, they're at the end of the rope as far as meds go, and they're looking for something. What's the next thing I can do? And you can say, well, we can do deep brain stimulation, which we know is going to make you a lot better. Or you can do this weird thing where we're going to infuse a bunch of crap in your head. And I don't know if it's going to work or not, right? I mean, I'm oversimplifying it a little bit. We don't enroll patients in trials unless we have a very high confidence that it's safe and it has good potential. But we don't know for sure if it's going to work. That's why it's a clinical trial, right? There's another therapy that they could get, deep brain stimulation, where they could get better. So we've been trying to make the argument that DBS shouldn't exclude people from these trials. We haven't won that argument yet. Here's the important point, though. Let's say that you've had DBS and, in 18 months, GDNF becomes an approved gene therapy for Parkinson's. Once it's out of the trial phase and it's FDA approved, anyone can get it. So if you've had DBS, you can get it once it's FDA approved. And I sort of envision, I think a lot of the DBS companies think that gene therapy and cell transplants are going to make DBS go away. And I don't think that's true. I think we're going to be doing combinations of therapies. I think we'll be doing, you've got Parkinson's, you've already got symptoms. DBS is really effective at helping the symptoms that you've already got. but let's do GDNF or a growth factor gene therapy because that's going to slow the progression of your disease. So I think we're going to do combination therapies.
There was a question about Oh, go on. I'm sorry.
No, I was just, it's funny. So I was just going to bring that up. So, so I'm not a neurologist. I'm a neurosurgeon. So I don't prescribe medications. Like someone asked about Exelon patch. I'm not a neurologist. So I'll have to dig up one of my neurology colleagues to come give you guys a talk. Same thing about hyperbaric oxygen. I do know a couple of neurologists that do that, but I don't prescribe medications or use those kinds of things. I'm basically I'm a very fancy plumber and electrician. That's pretty much it.
And how about the DBS for epilepsy? Do you do that, or is that a technique for people?
Yeah. So deep brain stimulation is an interesting thing. It started in movement disorders. So it started in tremor and then moved to Parkinson's. What we've learned about DBS is that it's safe and it's very effective at modifying brain circuits. And so it's now FDA approved to treat epilepsy. You can use DBS in a certain part of the brain. It doesn't stop the seizure from happening, but it stops it from spreading. So it in theory keeps it from becoming a grand mal seizure or generalized seizure. There's another technique that's similar to deep brain stimulation. It's called RNS, or responsive neurostimulation, and it's a device where you have electrodes that can sense a seizure and then stop it by stimulating in a different place. We've used it to try to help patients with tinnitus, as you alerted to earlier. It's effective for things like obsessive compulsive disorder. So we do deep brain stimulation to help people that have OCD. It can help reduce their obsessions and their compulsions. So it turns out that a lot of these disorders are network disorders. It's a particular network. And we've got a lot of different well-defined networks in our brains. There's networks that control movements. That's what we are trying to affect with cell transplants, gene therapy, DBS. But there's other circuits that underlie emotion or mood. There was a trial to try to help Alzheimer's disease. There was a DBS trial that started in Canada to try to help patients with Alzheimer's disease. So it's an exciting time for modulation in general, whether you're using electricity or viruses or cells.
I wondered if you could speak to dystonia in terms of any of those kinds of treatments or therapies.
Yeah, so dystonia is very effectively, in most cases, treated with deep brain stimulation. It's not, we've had some patients in the gene therapy trials that have had, components of dystonia. A lot of patients with Parkinson's they'll have some foot inversion. Their foot will turn in, or they'll have a little bit of torticollis. But there's not been a gene therapy trial yet directed specifically at patients specifically with dystonia. Part of the reason for that is, we really don't know where in the brain dystonia comes from. And, Parkinson's is relatively easy. And what I mean by that is, there's a well-defined circuit in the brain that's affected by Parkinson's. It's a specific part of the brain where most of the cells are dying off. That's where the dopamine cells are dying off. It's an area called the substantia nigra. And we know where those cells connect to in the next part of the circuit. So, it's easier to sort this out in Parkinson's. Things like dystonia, we don't know. There's a very abnormal signal in the motor circuit. We just do not know where it's coming from. One of my partners in San Francisco is one of the smartest guys I know, spent years and years trying to figure that out. Just never could. It's tough.
Kathy has a good question for you there about any therapies for freezing of gait. Can you be more specific in terms of targeting parts of the brain or with different therapies?
Yeah. So freezing a gait is a tough one too. We had a very exciting moment, and in science, moments last for a couple of years. So we had a very exciting moment in the late 2000s, like 2008, 9, 10. There are patients that most patients that have Parkinson's disease that have freezing a gait, it does get better with DBS and it does get better with gene therapy. But there are some patients where it doesn't. And there's a specific type of freezing. We call it on-period freezing, where people freeze whether their meds are working or not. And on-period freezing is notorious for not getting better with any of these surgical treatments that we use. So a group in Australia and then a group in Italy published papers on the stimulation of this kind of largely ignored target in the past. It's called the pedunculopontine nucleus. I think it was ignored because people couldn't pronounce it. It's the PPN. And the PPN is another part of this motor circuit. It's kind of more connected to spinal cord function. It's kind of right on the fringes of the brain motor circuit. But these guys showed that it would help freezing a gait. And we got very excited about this. And we actually did about 4 or 5 patients who had sort of traditional DBS and the sort of traditional targets like the subthalamic nucleus. And their freezing a gait didn't get better. And it's interesting. Those patients their freezing a gait looked awesome for about 6 months. And then the effects just started to kind of wane. And then the groups that originally published their results did follow-ups and said, the results don't seem to last. So we don't know really why that is. So freezing of gait, balance is a huge problem, right? And balance is hard because it's not just the motor circuit. It's the motor circuit. It's your equilibrium circuit. It's your visual system. We've all got little joint position sensors. That's how if your eyes are closed, you kind of know where your limb is in space, even though you can't see it, because we've got little sensors in our joints that tell us where our limbs are. So all of this information has to get integrated to help with balance. And so balance is a really hard thing to try to get at. So we haven't had a lot of luck with helping balance.
I know something that does help balance. If you haven't had physical therapy, you can definitely improve your balance with training. So don't give up. Come see a therapist. In fact, Dan is sitting over there with a great balance device he has. So I know that, there's lots of evidence that therapy can help balance. So,
yep. And I think the reason for that is when you do therapy, it engages all those systems.
Yeah, exactly.
Yep.
Cool. I have one more question. If you don't, I think we got about 5 minutes or something. I know you mentioned using your own skin cells, which is really cool. And then using them, I guess you infuse them into the brain or you use them as the vector. I wasn't sure, but my question about them. Cells. Okay. Because if those cells have Parkinson's, how long do you expect them to live in the brain and do their thing if they get sick, I guess, if they have Parkinson's, or is that a thing? I don't know.
Yeah. So it's a good question. I mean, and this is one of the things. So one of the other things that brought me to Arizona is there's a researcher who I collaborated with many years ago in that very first growth factor trial. His name is Jeff Cordover, and Jeff was at Rush University for many years. So Jeff was recruited to Arizona State to start the ASU Banner Neurodegenerative Diseases Research Center. And Jeff is a very prolific researcher, has worked on stem cells in the past and also fetal cell transplants. And we actually have a grant from the Michael J. Fox Foundation to do cell transplantations in a very specific type of Parkinson's patient that has what we call a Parkin mutation. And we're going to be doing those procedures. The plan is to actually do them in Phoenix. So I will come up to Phoenix and do them. But some prior cell transplant studies showed that if you examine the brains of patients that have had a fetal cell transplant, for example, and when they eventually die, if the family is and the patient have been kind enough to donate their brains to let us examine them, what you see is in the transplanted cells, you'll see little abnormal aggregates of proteins. These are things called Lewy bodies, for example. Lewy bodies are little abnormal proteins that can sort of collect in the cells of patients that have Parkinson's. There are similar proteins that accumulate in the brain cells of patients that have Alzheimer's disease. And so this is a thing. It's not that the skin cells have Parkinson's, but whatever environmental changes that have happened in this part of the brain do seem to affect the cell transplant as well eventually. One of Jeff's very exciting concepts is this idea of sort of antibodies for your cells that keep these abnormal proteins from accumulating. So Jeff has some intracellular ways to try to block that he and others are working on. So it's a valid question, right? We don't know what really causes Parkinson's, but we do have to worry about that with a cell-based approach. Yeah.
Well, I think it's really interesting in that you mentioned your genetics may in the future guide what therapies you get, like all these things you're talking about. Because they're doing that, there's a lot of genetic testing being done. People are choosing to do that and making it more personalized. I don't know if you have anything to say about that, but it's more of a puzzle, more things to put together, but it may be one of the reasons that things don't always work in clinical trials. You have such a mixed group of people and you're trying to do this one technique.
Yeah, no, that's very true. And it's true on multiple levels. I didn't really get into it, but one of the powerful things about this MR guided technique for gene therapy is that the targets vary in patients quite wildly. Some people, the putamen, for example, is this part of the brain that we try to infuse. Some people have a really big putamen. Some people have a really skinny one. And the FDA wants you to say, okay, what dose are you going to use? And you're going to use that in everybody. And the answer is no. We don't want to use that dose because, what might be a good dose for one person isn't for another. The other thing is that, people that are on the call know that Parkinson's is a very, what we call a heterogeneous disease. What it means by that is, one person, Mary who's on might have a lot of tremor. Karen might have no tremor at all, but might just have some stiffness and slowness. Dan might have freezing a gait, and Newton might not. So it's a very heterogeneous collection of symptoms, and it's tricky. And on the one hand, you don't want to, you'd like to say, well, we're going to do a trial and everyone's going to have the same characteristics, but at the end of the day, you want this therapy for everyone that's got Parkinson's, no matter what their mix of symptoms is. So our approach has been to really try to, within reason, and what the FDA lets us get away with, to sort of take all comers, tremor, no tremor, stiffness, no stiffness, and see what we get.
Well, that philosophy of personalized sort of care is also trickling down to exercise. So I have to speak up for exercise because people with different distributions of motor and non-motor symptoms either prefer different types of exercise, or they may respond to different types of exercise differently. So for those of you out there, there's a lot of options, and don't give up, because there's, that's going to be the future of exercise, is trying to figure that out. So,
yeah,
wow, that was really exciting. Anyone else? I think that's about time, or very close.
I want to ask one last question here, because I think Alex kind of had this question too. Is how long do you think until something like this would be like FDA approved and available? Because it sounds really promising. And then also thinking about like the cost, like any idea what that's going to look like?
Yeah. So a phase 2 study takes about, just depending on how long the follow-up is, but it can take three years easy from start to finish, and giving the FDA data enough to have them make a decision. So for example, to look at the GDNF program, that gene therapy program, that's hopefully going to start phase 2, I'm hoping before the end of the year. So that's putting us like 2026-ish, maybe, if everything goes well. The stem cell trials, the phase 1 trials, Blue Rocks has already started. The Aspen trial is probably going to start around this time next year. It's slow, which is frustrating for patients who need something now, right? Or they need something, like I think it was Alex said, what's the outlook for someone who's 67? The outlook's actually pretty good. I really do believe that we'll have an FDA approved biologic within the next, or in about 5 years is my guess. But the future has never been brighter for these kinds of therapies, because there's just a ton of them that are about to get on a playing field.
Great. Well, thank you so much, Dr. Larson. We're lucky to have you here. We look forward to hearing more about all these studies and have you back. And thank you, everyone, for coming. And this is recorded. You can let people know if they'd like to listen to it. It's on our website. You'll be able to find it in a few weeks. I don't remember how long it takes.
It takes some time to do the editing, so we can block everyone out.
Yeah.
For privacy.
Great. Okay. Thanks.
Fair enough. Thank you guys very much. I appreciate it.
Great.
Thank you.
Bye-bye.
Bye. Thank you.